So good afternoon, everyone. Today I have a very simple presentation about a case report that came to us. It was about a 52-year-old male with an HIV infection classified accordingly to the CDC, CDC C3 due to its levels of CD4 T cells. They were very low, as we can see, with a very high viral load. This patient actually stopped treatment from 2012 to 2019. Uh, um, One important information we had is that he had a recent trip to Brazil. Was it in the previous month? The familiar couldn't actually exactly tell, but we believe it was in the previous month before we admitted him. The patient entered first to a respiratory diseases unit due to fever, asthenia, cachexia, strangely, without any history of cough in the patient file. He has an RT-PCR performed on a bronchoalveolar lavage fluid positive for pneumocystis gyrovesi pneumonia, a very common respiratory mycosis found in this type of patient, as we all know, and Azil Nielsen of the same product that actually come out negative. So no mycobacterium was found. We know tuberculosis is actually very common also in this type of patient, but the patient further evolved with a bleeding disorder, with abundant hemoptysis and bruises, persistent of fever. Next slide, please. So clearly worsening his condition. So further blood studies revealed pancytopenia, high inflammatory parameters, namely ferritin, lactates, high fat content such as triglycerides levels, and a clear clotting disturbance marked by a low functional fibrinogen. Sodium and albumin actually also dropped, probably due to intense inflammatory condition, as we all know. So the patient was quickly transferred to the ICU with pneumocystis gyrovesi pneumonia diagnostic under the patronized treatment with cotrimoxazole and suspected hemophagocytic lymphohistiocytosis with a score of 96 to 98%. Mainly due to the pancytopenia, higher ferritin, triglyceride levels with low fibrinogen. We actually even asked about the levels of CD25, that it's a soluble interleucin alpha receptor marker of inflammation. Because of these specific high values in this hemophagocytic syndrome. And we later on it came to us that it was made outside of the hospital, but it was very high, which is very typical of hemophagocytic lymphohistiocytosis too. So to document actually hemophagocytosis, a bone marrow aspirate was requested. Next slide, please. So as we can see with the arrows, well, I didn't expect it to be so small in here, but in the yellow arrows, it was actually pointing out numerous yeast-like bodies inside macrophages with morphology suggestive of histoplasma species. Uh, Sorry, I was just trying to. Okay, it's not possible. But anyway, they were round or oval in shape with a chromatin nucleus, a basophilic cytoplasm, and a capsulated and encapsulated something that we cannot quite see here, but inside this cell with the nucleus, we can see those yeast cells inside, and those are typic. Yes, not this one. This is the actually the histiocyte nucleus, but these small rounded cells around the cytoplasm, those are the actually the yeast cells. Sorry. Uh, we can also next slide, please. So despite mostly within the cells, we can also see maybe in this image we can see it better. So despite mostly within the cells, we can also see one here outside the cell with a round shape and accenting chromatin nucleus. That small dot Actually, in the periphery of the small cell, is the chromatin. Yes. So this actually honestly came as a surprise. We expected something slightly different, by far more common in our lab in this type of patient, that is Leishman-Donovan bodies of leishmaniasis, but it was clear by the morphology that it was something else. Next slide, please. So was it histoplasmosis? So bone marrow cultures were requested and incubated at 2 temperature exactly to highlight one of the most characteristic feature of this fungus, that is the dimorphism that I will discuss a little bit further. Uh, those uh, those are the actually the culture media we used: Columbia blood agar, subarachnoidextrose agar, with or without antibiotics, uh, to stimulate the different the two main types of growth. Of the fungus, and molecular tests also were requested. Bone marrow blood PCR polymerase chain reaction, that it was in an outside laboratory in a reference one. Next slide, please. So after 7 days, as we can see in the subrod culture media, at 25 degrees, imagine room temperature or natural environment, we documented growth of these velvety, cottony, white colonies. And the next slide, please. And the next slide shows the reverse side of them. There is a yellow reverse. After we flip actually the culture media, we can see the other side, and it's a yellow reverse side, and it's very characteristic of of this type of fungus. Actually, it's a very dangerous form for the technician, because it's the infectious form that is the mold form, but yeah, it's not. But this is just not enough to diagnose. Next slide, please. At a microscopic evaluation of a lactophenol blue mount preparation, that is the special dye we use for to visualize fungi cells, we can see IFA, that this oops, sorry. We can see the IFA. It's a very shame that I cannot point it out, but this almost hairy structures. We cannot see it very well. Maybe in the next slide, please. And then we can return to this one. That long structure, almost like a hair. Those are the IFA, and we can see that they are septate. They have small, just small. Um Sorry, we cannot exactly see here. There is septate and hyaline, and but what we can really see in this macroconidia, there are large, round, one cell and thick walled and tuberculate. It's this round cell that we are seeing here, the asexual form actually of the fungi, with these small projections, these little cylinder type projections. It shows that the macroconidia are actually tuberculate and thick-walled. Next slide, please. So at 35 degrees Celsius, we can see at a warmer temperature that actually is trying to mimetize the body temperature. The fungus actually grows as a yeast with a typical white, smooth, creamy, and yeast-like colonies. And the microscopic evaluation, next slide, please, actually shown round to oval, very small budding and thin wall cells. All these little round cells that we are actually seeing here, very little cells. It actually could add a bit of certainty about the variant of Histoplasma capsulatum, actually capsulatum variant capsulatum, because the African variant has a more large cell, has larger cells. So this is the yeast form. Next slide, please. So the isolate was identified as Histoplasma capsulatum based on its morphological features. Next slide, please. And molecular results confirm the diagnosis, bone marrow PCR, and confirm Histoplasma capsulatum. So histoplasmosis. Histoplasmosis is an infection, as we know, caused by a fungus called histoplasma. Histoplasma has two variants. Histoplasma capsulatum is the species and has two variants: Histoplasma capsulatum, variant capsulatum, and du Boisi capsulatum. Actually, near worldwide has a near worldwide distribution, but the variant du Boisi is actually located in Africa. It's very important, as we saw in the previous slides, to actually know that it's a thermally dimorphic fungus, that's because the fungus exists as a mold in soil and as a yeast, as a virulent form in the host. The fungus lives in the environment, particularly in soil that contains large amount of organic material rich in nitrogen, such as bird or bat droppings. It exists, as I said before, through the world, but it's far more common in the United States of America, mainly in the Central and Eastern states, also parts in Central and South America, in Latin America mainly, Africa, Asia, and Australia. In Europe and Portugal, the most of the cases are imported from endemic area, but a large study and a very recent one showed that autochthonous infections, mainly in Italy, and one also documented in Spain and in Ireland, are exists in Europe. So maybe histoplasmosis has a more wider distribution than we all think. Infection actually occurs after breathing in the microscopic fungal spores, airborne microconidia from the air. Primary cutaneous histoplasmosis and solid organ donor derived histoplasmosis are extremely uncommon. There was a case in a patient after a liver transplant, but it's actually extremely uncommon. Next slide, please. So this is from CDC, and as I said before, so spores that are aerosolized and dispersed are inhaled into the lung by a successible host. The warmer temperature inside the host signal a transformation into the yeast, and the yeast are then phagocytized by immune cells and transported to the regional lymph nodes. From there, they travel to the blood in the blood to other parts of the body. Next slide, please. As we all know, mild histoplasma, this type of infection and a fungal infection in an immunocompetent individual almost is asymptomatic. So in 99% of cases, patients are asymptomatic, and for the rest of the cases, about 1%, mild and self-limited infection occurs. When symptomatic infection occurs, um, it usually presents after 3 to 17 days after exposure, mostly as acute pulmonary infection with fever, cough, chest pain, chills, myalgia. But in immunosuppressed persons or persons with weakened immune system, it is disseminated histoplasmosis can occur, such as the case of our patient, and the mortality is very high. The the fungus actually attack mainly the reticuloendothelial system, such as liver, spleen, and bone marrow, and can disseminate. And it's a very dangerous and a very dangerous condition with high mortality rate. So diagnosis can be made through many techniques such as antigen detection, antibody test, culture, microscopy, and PCR. Antigen detection in urine, serum, or other body fluid is the most widely used in endemic countries and is a sensitive method for acute pulmonary and disseminated histoplasmosis, and can aid to rapid diagnosis. Antibodies actually maybe not as useful because it takes 2 to 6 weeks to develop an antibody response. So it's not very useful for acute histoplasmosis, and in immunosuppressive persons might not they actually might not mount a strong immune response. So maybe it's not as useful as other techniques. Culture can be performed in any product, but can take six weeks to become positive. In the case of our patient, it actually took only 7 days, but can be more. Microscopy to identify the yeast in tissue can provide a quick proven diagnosis if positive. PCR are mainly from cultures because in the body fluids it's still experimental. That's why in our patient we do it in the we did it in the reference laboratory outside our hospital. um, Treatment-wise, mild to moderate cases will often resolve without treatment, but in severe forms, pulmonary acute histoplasmosis or disseminated histoplasmosis, antifungal agents such as amphotericin B and itraconazole is indicated. So we have to be aware about the risk groups. People in endemic areas, particularly those who have occupation or participate in activities exposing them to soil that contains bird or bat droppings, people that actually work in constructions, in caves, are at risk. So for disseminated histoplasmosis, immunosuppressed patients with HIV, organ transplant, or patients with cancer, with immunosuppressive medications, infants or adults 50 years old or and older, those they have to be aware of this of the possibility of this infection. Next slide, please. So for take-home messages, we should always be aware of certain types of infections, such as fungal infection, particularly in certain risk groups. Histoplasma is of worldwide distribution, but disease is more reported in certain areas. So in case of suspicion, always ask for a detailed travel history. The travel history was very important in our case. In case of suspicion, always discuss with the laboratory personnel. It was very important that when the clinician ask us and provide us with the patient history, so that we can look and search for the correct diagnostic tools and use the different diagnostic tools so that we can add to the correct diagnosis for the patients. That was the case of our patients. Immunocompromised patients, such as those patients with HIV, cancer under treatment, suppressed of any origin, are at high risk for severe disease and death. So prompt diagnosis and treatment are crucial. Thank you very much.